We begin with a 21-year-old male medical student. For 2 years, he has suffered from a severe anxiety disorder that resists pharmacological intervention. Looking at this clinical chart, his macroscopic physiology appears flawless. He maintains optimal oxygen saturation at 100%. He presents with normocardia, resting at 67 beats per minute, and ideal blood pressure at 113/76. To achieve these numbers, his daily regimen includes a selective serotonin reuptake inhibitor, a non-selective beta blocker, a tricyclic antidepressant, and the concurrent use of 2 distinct long-acting benzodiazepines. The numbers on that chart do not indicate a healthy patient. They indicate a state of profound chemical suppression, where the somatic expressions of the fight-or-flight response have been artificially paralyzed. When dealing with heavily medicated psychiatric patients, stable outward vitals are often a false signal. They entirely mask the microscopic neurochemical chaos and structural damage occurring beneath the surface. To understand this chaos, we must look past the macroscopic vitals and examine the hepatic system, specifically how the liver clears these drugs. The hepatic CYP2D6 enzyme acts as a clearance gateway. Sertraline physically blocks it. Consequently, imipramine and propranolol rapidly accumulate, spiking in the blood. This triggers severe cardiac conflict. Toxic imipramine sends a massive acceleration signal, while propranolol simultaneously sends a massive deceleration signal. These 2 opposing vectors alter repolarization kinetics. The heart receives simultaneous, intense signals to aggressively accelerate and aggressively decelerate, creating a highly unstable electrophysiological state. This specific combination of polypharmacy does nothing to treat the underlying anxiety. It creates a cardiovascular tug-of-war that elevates the risk of arrhythmogenesis and sudden hemodynamic collapse. The systemic dangers extend upward from the liver into the central nervous system, particularly regarding the rationale behind the dual benzodiazepine prescription. Prescribing both clonazepam and diazepam represents severe therapeutic duplication. Both compounds target the exact same regulatory pocket on the GABA-A receptor complex. This dual modulation forces the central chloride ion channels to open with extremely high frequency. This massive influx of negatively charged chloride ions deeply hyperpolarizes the neurons, inducing a state of global, nonspecific CNS depression. In this cross-section, you can see how the brain defends itself against this chemical depression. To restore normal excitability, the neurons physically pull their own GABA-A receptor channels out of the synapse, internalizing them inside the cell. Curing an anxiety disorder requires a structural process called fear extinction learning. The ventromedial prefrontal cortex must physically grow new synaptic connections to the amygdala to teach it that a stimulus is safe. That structural growth relies on long-term potentiation, which only occurs in the presence of precise, high-frequency neuronal firing. This glowing neural network illustrates the required electrical activity. But under the CNS depression caused by benzodiazepines, the firing dims and slows to a halt. The drugs intended to soothe the panic actively paralyze the exact neuronal firing required for neurogenesis. By arresting neuroplasticity, the medications make structural recovery biologically impossible. The biological barriers to recovery extend beyond pharmacology. We must analyze the systemic metabolic environment, specifically the patient's reliance on highly processed instant carbohydrates. This nutritional breakdown of an instant poha meal shows 2 physiological triggers. 960 milligrams of sodium artificially expands plasma volume, mimicking sympathetic arousal. Synthetic preservatives like BHA and BHT actively degrade intestinal tight junctions. Once that barrier breaks, gut endotoxins leak directly into the systemic circulation. The immune system responds by releasing pro-inflammatory cytokines that cross the blood-brain barrier, seeking out and activating microglia in the amygdala. This localized neuroinflammation heavily upregulates an enzyme called indolamine 2,3-dioxygenase, or IDO. This flowchart demonstrates the kynurenine shunt. Under normal conditions, the amino acid tryptophan flows down a pathway to synthesize serotonin. But when inflammation activates IDO, the enzyme physically redirects the flow, hijacking the tryptophan and forcing it to become highly excitotoxic quinolinic acid. A selective serotonin reuptake inhibitor relies on the presence of endogenous serotonin to trap within the synapse. If a highly inflammatory diet actively starves the brain of serotonin at the source, the SSRI becomes functionally useless. The failure in monoamine synthesis is compounded by a total breakdown in the endocrine system. The patient presents with profound hypovitaminosis D, recording a severely deficient 6.64 nanograms per milliliter. Within the central nervous system, vitamin D functions as a neuroactive serosteroid hormone, regulating the transcription of hundreds of genes necessary for brain health. The brain relies on two specific rate-limiting enzymes, TPH2 and tyrosine hydroxylase, to manufacture serotonin and dopamine. This diagram shows the active metabolite of vitamin D entering the neuronal nucleus. It binds to the receptor complex on the DNA, acting as a genomic transcription factor to physically build the shapes of the TPH2 and tyrosine hydroxylase enzymes. To address his nutritional deficits, the patient attempts a daily botanical intervention using a sea buckthorn extract. Standard clinical guidelines require 30 to 60 milliliters of this concentrate per day to reach biologically active serum levels. By consuming merely 2 milliliters, the patient is providing less than 10% of the minimum therapeutic threshold, rendering the practice pharmacologically inert. He misses a critical opportunity to leverage the extract's dense concentration of omega fatty acids, which the brain desperately needs to restore neuronal membrane fluidity and ensure neurotransmitter receptor flexibility. Correcting these core hormonal and nutritional deficits is the biological prerequisite for neurotransmitter synthesis and psychiatric recovery. The patient's chronicity is maintained by a triad of biological failures: an antagonistic polypharmacy trap, an inflamed gut-brain axis, and complete endocrine starvation. The first corrective step requires a physician-supervised, highly structured taper, specifically the Ashton Manual protocol, to eliminate the therapeutic duplication of the benzodiazepines and rescue the GABA-A receptors from severe downregulation. The second step is biochemical correction. The patient must undergo aggressive, high-dose vitamin D replenishment and immediately eliminate the intake of synthetic, heavily processed carbohydrates. The third step addresses behavioral neuroplasticity. The patient must shift away from constant high dopamine digital consumption, re-establish strict circadian rhythms, and allow the brain to re-engage its default mode network. Pharmacology cannot cure an anxiety disorder. It only creates a temporary window of chemical stability in which behavioral learning can occur. Curing the anxious brain requires clinicians to look past the chemical paralysis of somatic symptoms. True recovery demands rebuilding the specific biological architecture required for active neuroplasticity.